And we are live now on YouTube, and I'm going to start recording as well.
Teacher Joya, I think we can start.
Okay. Now on YouTube, and I'm going to start recording as well. Sorry about that.
All right. Assalamu alaikum, everyone. Welcome to the COVID-19 vaccination for 12 to 16-year-olds with Muslim Educational Trust. My name is Juveria Sayed, and it's my honor today to have Dr. Imran Mohammadi, a renowned physician, infectious disease specialist attending at Providence St. Vincent Medical Center. Dr. Mohammadi was taught early in his medical career that one of the most important responsibilities of a physician is to teach. Teaching patients, teaching colleagues, and teaching future generations of doctors is a duty that all doctors accept as part of an unspoken oath. Dr. Mohammadi attended University of California, Los Angeles as an undergrad and went to medical school at Royal College of Surgeons in Ireland, where he did his residency in internal medicine. He did his residency in internal medicine at Providence St. Vincent Medical Center and fellowship in infectious disease from OHSU. Dr. Mohammadi, it is an honor to have you here today, and we greatly appreciate you lending your expertise to the Muslim community and the community at large for this very important topic. Without any further ado, I'll have you take over, and then if you have any questions, we'll ask those questions after your presentation. Dr. Mohammadi?
Sounds good. Thank you very much for that introduction. Assalamu alaikum to everybody who's joining here. It's a pleasure to be here again and talking to you about vaccinations. I think it's been about a month and a half, maybe 2 months since we did the original presentation on vaccines. And I will reference that a little bit, but for the most part, for today, I wanted to talk specifically about vaccinations for our children. Many of you have probably heard that the vaccine, the Pfizer vaccine, is now available for children 12 to 16 years old. And I'm sure lots of questions have come up similar to when the vaccines were released for the adults. Similar questions probably arise, well, should we be giving our vaccines to children as well? So I'll discuss some of the aspects to those questions, but also leave some time at the end for specific questions if I might be able to answer those. So this isn't a theoretical question for me. I am a father. I have a 13-year-old boy. And so we had to make that decision ourselves. We had to decide, okay, is it time for him to get the vaccine, and what are the potential consequences of that? What are the things that we needed to investigate before we made that decision? And when we did make that decision, we didn't have a lot of information, in all honesty, at that stage. But since that point, we've developed a more robust literature and have collected more data to provide some more information, and I hope that'll be helpful. So in terms of just understanding the messenger RNA vaccine, the common side effects in adults, and then the vaccine effectiveness in adults, I'll refer you to the previous talk. I think it's still available on YouTube and through links on the MET website. So if you have a chance and you haven't already looked through some of that information or watched that video, then I would recommend you do so. It does have a lot of information about how the vaccine works, what are the things that we were concerned about with the vaccines, and what data we had to say, no, these are very safe and effective vaccines. So why should children ages 12 to 16 get this vaccine? And so let me start by just talking a little bit about the data we have on the COVID-19 infection itself in children. About 1.5 million American children between the ages of 11 and 17 were diagnosed with COVID between March 2020 and April 2021, and that's according to the CDC data. Since the pandemic began, roughly 500 kids ages 17 and younger have died from the vaccine. But most children infected with the vaccine have only had mild illnesses. And so that is one aspect to be aware of. And I think this slide really outlines the risk overall by age. And I think it's an important slide for everybody of every age to have an understanding of. And let me walk you through this slide just briefly. First of all, this slide compares everybody to the ages of 18 to 29-year-olds. So if we consider that our sort of baseline comparator, then you can see that as you get older, the risks for both hospitalization and the risks for death increase. And so you are, much more likely to be hospitalized as you go up in the age groups there, and you're much more likely to die from COVID as you go up in the age groups there. But in the reverse end, it's kind of a little bit different. There's, you would think that the risk for hospitalization or the risk for death would be smaller as you get or increased as you get further from that midline point, but it's actually just what we would expect. The younger you are, the less likely you are to get hospitalized with COVID, and the younger you are, the less likely you are to die from COVID. And they broke it down into these age groups. Unfortunately, it doesn't help us as much when we're talking about the vaccine, because we know we're not vaccinating 5 to 12-year-olds just yet. And so that group is kind of a large group to consider. But what we do know from the data that's come out in the last several months is that 12 to 17-year-olds are the group that tends to transmit it more than the group 0 to 11-year-olds. So we're worried a little bit about that group from the standpoint of transmissibility, and we are worried about that group a little bit more from the standpoint of some of the side effects, or not side effects, but the effects of the COVID vaccine itself. So again, back to the information that we have about the COVID-19 infection. Most children, mild disease, but there are some serious complications associated with COVID-19 in children that one should be aware of. The one that we've discovered and are most worried about is multisystem inflammatory syndrome in children. This is a side effect of the COVID infection, not the vaccine, but the infection itself. And it's an effect that's quite severe. It's inflammation of multiple organs in the children's bodies. Particularly of worry are inflammation of the heart, the lungs, and the kidneys. And in rare cases, these can be permanent problems in those organs. So it can cause permanent damage. And there have been deaths associated with this as well. As of June 2nd, where the data was collected most recently, there have been about 4,000 cases in the US of this and 36 deaths associated with this. Other side effects or other effects of the COVID-19 infection include brain inflammation, encephalitis, long-term breathing complications, and even myocarditis, and inflammation of the heart is associated with getting COVID infection, okay? Risk factors for these complications and risk factors for COVID in children, well, it's very similar to the risk factors in adults. We know that obesity, diabetes, asthma, chronic lung disease, sickle cell disease, and immunosuppression put adults at more risk, but it also puts children at more risk. Fortunately, fewer children have these conditions, so we're not as worried, but keeping in mind that the children between the ages of 12 and 18 who do have some of these conditions are at more risk of contracting and having serious complications from COVID infection. Similarly to adults, we're also seeing more risks amongst people of color in this age group as well. So our African-American brothers and sisters, Hispanic brothers and sisters have been shown to have more risk in the adult group, but also in the child group from the 12 to 17 age groups. And unfortunately, we don't have a lot of data for other ethnicities, but we do think that there is a lot of overlap in that people of color are at more risk, not just purely from access to healthcare issues, but also for other reasons. So the other part of this is, well, if the children are mostly getting mild cases, then should we be as worried about them? Well, it's not just about the cases that happen amongst children, it's also about the cases that they can then transmit to adults or people who can't get vaccinated or family members who haven't been able to get vaccinated. So transmissibility amongst children in the age groups of 12 to 17 are similar to, if not more, than transmissibility amongst adults, and especially within the household. There is some suggestion that transmission from children to adults is slightly less, but that hasn't been verified very well. And so it's still a question mark from our standpoint. The fraction of asymptomatic transmission, though, because of the fact that more kids have milder cases or undetectable cases, was higher in the in kids compared to adults. And then there is some limited data to suggest that children under the age of 11, the transmission rates are quite low, especially when they were measured in educational settings or childcare settings. So our worry from before of, what about kids going to school? What about kids going to daycare? Well, our worry can probably be a little bit less at this stage in that population, in the children under the age of 11 population, based on a lot of data that's coming out from not only the United States, but also internationally. So the push for vaccination amongst the ages 12 to 17 sort of is outside of that. And we do know that 12 to 17-year-olds do transmit the disease quite effectively, even in school settings to some degree. All right, so what about the vaccine? So far for ages 12 to, I put 15 here, but the 16 and up for Pfizer was already approved. So we already were vaccinating some kids in that 16 to 18 age group with Pfizer vaccine because that already had the approval. But now we have approval to vaccinate ages 12 to 15 as well. The studies that were done, the main study, and we've done phase 1, 2, 3 trials, okay? And the phase 3 trial that was just completed a few months ago enrolled a little bit over 2,000 people. Half of them got the placebo and half of them got the vaccination. And amongst the placebo group, 18 people had confirmed cases of COVID-19, symptomatic cases. And none of the children who had the vaccine contracted COVID, either symptomatic or detectable by PCR. So I think this shows that it is at least as effective, if not more so, in this age group compared to adults. So there's no question about efficacy here. It is very efficacious in the 12 to 15-year-old group. It was well tolerated, the vaccine was, amongst the people who got the vaccine. The side effect profiles, we talked a lot about this in that last talk, about what side effects to expect from the vaccine? What side effects have we also heard about that are somewhat unexpected? And this was very similar, consistent with 16 to 25-year age group comparators for the adult vaccine, okay? So, or the adult studies, I should say. So the side effects are very similar. There is one that I will talk about a little bit more, and that's the myocarditis question, and I'll get to those slides a little bit later. But the other thing is immunogenicity, the checking for the antibodies 1 month after the second dose. This group had similar antibody levels compared to 16 to 25-year-olds who got the same vaccine in other studies. So again, that just is there to help us understand that it is very efficacious from a immune standpoint, that these vaccines produce an immune response similar in 12 to 15-year-olds compared to the 16 to 25-year-olds that they were compared against. There is some concern, and this is over the last month and a half or so. Again, we've been keeping track of all this data. The one thing that we do with these vaccines is any side effect of the vaccine is reported through the special computer reporting system, and all that data is kept by the CDC and evaluated, day to day, week to week, and published out to the infectious disease community. So we are keeping watch over anything that may have been missed in the original studies with the 1,000 kids that were vaccinated, because now we've got data for thousands of kids, multiple thousands of kids who've been vaccinated at this point. Okay, and the one thing that has emerged as a concern is myocarditis and pericarditis. So what are these? Myocarditis is inflammation of the heart muscle, and pericarditis is inflammation of the heart sac. The heart sits in the sac that it's surrounded by, and that organ itself can also become inflamed. Keeping in mind that these conditions are not just associated with vaccinations, they're also associated with other conditions. You can get myocarditis or pericarditis as a result of viral illnesses. You can get it as a result of other autoimmune problems. You can get it as a result of sometimes drug allergies, those kinds of things. But what we've noticed is there have been, I would say, several cases of myocarditis or pericarditis felt to be associated with the COVID-19 vaccination in younger population. And I don't mean just kids here. We were looking at 12 to 39-year-olds, okay? So these numbers, sometimes some of them will overlap because of the way the studies and the data is collected, but just keeping in mind that younger people getting the vaccine may be at slightly increased risk of this condition. Now, that being said, this condition is still extremely rare. So for people aged 12 to 39, there have been approximately 12.6, or let's say 13 cases per 1 million doses of vaccine administered, okay? We put it like this because not all of those cases were in people who got 2 vaccines. Not all of those cases were, reported, or I should say some of them were as a result of the first dose, but mostly they were as the result of the second dose. What we also know is it was a little bit more predominant in males than females, and it was more predominant after that second dose, as I mentioned, okay? When they looked at subgroups, so they looked at kids between the ages of 12 and 18 who'd gotten the vaccine. In this one small case report, they looked at about 40 cases, and the vast majority of those cases that ended up going to the hospital, not all of them did, but the vast majority of them, they were only in the hospital for about 2 days. Only 2 of those cases ended up requiring some intensive care unit stay, and none of those cases have resulted in any deaths. And that's true not only about the small case reports, but all of the studies that have been collected, all the data that's being collected by the CDC so far in the 12 to 18-year group. None of the myocarditis or pericarditis cases have resulted in any deaths. Okay, so overall, what does this mean in terms of comparing the risks of vaccination to the benefits of the vaccination? So this was a slide that I took from there's a group called the AICD or ACID. They're the organization that approves vaccinations and particularly for childhood vaccines. And they're having a meeting as we speak. Their meeting started yesterday. It goes through tomorrow to look at all the data for the myocarditis and to say, okay, yes, we all agree that the risk is still very low and that the benefits of the vaccine still heavily outweighs the risks of the vaccine. And so they put this slide together. And to think about it this way, for every 1 million doses of vaccines that we give to girls aged 12 to 17, 1 million doses of vaccines to those girls would result in 850,000 COVID-19 cases prevented. It would result in 183 hospitalizations prevented. It would result in 38 ICU admissions prevented, and it would result in 1 death in that age group prevented. And the payoff for that, the downside to that, is there would be about 8 to 10 cases of myocarditis as a result of administering 1 million doses of the COVID-19 vaccine. For boys, it would prevent 5,700 cases of COVID, 215 hospitalizations would be prevented, 71 ICU admissions would be prevented, and 2 deaths would be prevented. And the payoff for that would be that we may have about 56 to 69 cases amongst those 1 million doses of vaccination, 56 to 69 cases of myocarditis. Knowing very well that the vast majority of the cases of myocarditis that we've seen have been mild, if they resulted in a hospitalization, these hospitalizations lasted for 2 days or less, and very rarely did they require intensive care unit stay, and none of them have resulted in any deaths. So I want to give that perspective a little bit for what we gain by vaccinating versus some of the downsides. Now, this doesn't take into account some of the other sort of, downsides, which is the allergic reactions that we see. And again, the rates of the allergic reactions, when I talked last time, the number was about 6 allergic reactions per 1 million doses of vaccination for all comers. That was, that was the adults. That was the 16 to 80-year age groups. And that was true for both the Pfizer vaccine and the Moderna vaccine. So still, those allergic reactions are extremely rare. And again, what we know is if you've had an allergic reaction previously to a vaccine, then you should have this discussion with your doctor or the pediatrician, if we're talking about the kids getting the vaccine, and discuss the benefits and risks. We do know that there were certain vaccines that there was potentially more overlap, but really, even if you've had an allergic reaction, particularly mild allergic reactions to other vaccines, that the likelihood of getting an allergic reaction to this vaccine is still extremely low. Okay, so I want to kind of really, drive this point home, is that what we gain with the vaccine here, as you can see with this data, definitely is way more than we risk with the vaccine. As a community, as a group, as a whole, as a nation, the gains here are definitely way more than the risks are with the vaccine. And so, this is the slide that I kind of put together to drive that home. What we're talking about is the number of prevented cases also means the number of preventable cases downstream. So the number of cases that we prevent, these are people who have the potential of being infectious and therefore infecting others. And these infections are what we're trying to prevent with vaccination. These are the ones that would have the potential downstream consequence of infecting people who either cannot get the vaccine because they have an allergy or they have some other health reason for not being able to get the vaccine, but also for the people who get vaccine and have immune reasons why the vaccine may not be as effective in them. Those are who we're trying to protect here by getting the vaccination for kids. Okay. And so that's the whole point, is we're trying to reduce the number of more infections through vaccination. And so there is ongoing research going on for vaccination using the Moderna vaccine. The study hasn't been fully published yet, and therefore the Moderna vaccine hasn't achieved the emergency use authorization that the Pfizer vaccine has already obtained. Pfizer is already starting looking at vaccination for 6-month to 12-year-old children. That data is very early in its development, so I don't have a lot of information to provide for that, but just know that that is being studied at this point as well. And there are some additional vaccines that are being studied that you'll potentially hear about, in addition to the Johnson & Johnson vaccine, not just for kids, but also for adults. There's a vaccine that uses more of a standard protocol or a standard type of vaccine that people are looking into as well. And as we get more information on that, perhaps I'll be able to present that at some future date. Okay, so that's the main part of my presentation, just to kind of answer some of the more common questions that I've been already getting is, is it safe? Is it effective? Those are the two biggest questions. What do we know about the myocarditis, the pericarditis concern? Because that has been on the news to some degree, and that has been circulating, amongst the social media, platforms as well. And so I wanted to make sure people were aware that we are looking into that aspect. But what we do know so far is that it is extremely rare and overall very mild. And in and of itself, when we take it as a whole compared to what we gain, is probably not enough of a reason not to get the vaccine. So I will turn it back over to Joaria and see if there's questions that have come up. I'll stop sharing my screen so that if there's other things that I need to look at here, I can do so.
Thank you, Dr. Mohammadi. That was a very informative presentation and very, very comprehensive, and possibly answered a lot of the questions that many parents who are watching this presentation had. However, just one question that I'd like you to reemphasize is why is it so important for us to vaccinate the 12 to 17-year-old group when the rates are not as high? But why is it so important, so that that point gets driven to the parents and to larger community?
So the main issue here is we're trying to remove the reservoir of this virus from keeping on circulating. And in order for us to do this, in order for us to eliminate the virus from circulating in the community, the more people that are vaccinated, the better chance we have of eliminating this virus from the community itself. Because we know that there will always be some people who are not vaccinated for whatever reason. And we also know that there will be some people who are vaccinated who the vaccine will be less effective in. And as we start to get into a point where we have more of these variants, more mutations amongst the COVID vaccine, the efficacy of the vaccine becomes a little bit more questioned. And it doesn't mean that it's ineffective. It just means that there will be a larger fraction of people, even if they're vaccinated, in whom there's the potential of still contracting COVID. More than likely in those people, it'll be very mild to the point where it may even be asymptomatic. And then they could potentially then transmit it out as well. So in order to remove or reduce that risk as much as possible, the larger number as a whole that we can get vaccinated that have the potential of transmitting it to other people, vaccinated or not, is how we eliminate COVID from the community completely. So this isn't just about protecting our children. Yes, that is one of the benefits of getting the vaccine, that they are at less risk of developing COVID-19. They are at less risk of being hospitalized. They are at less risk of some of these complications. They are at less risk of dying. But the real reason, the more important reason, the sort of the community reason here is so that we can reduce the risk of transmission as a whole in the community.
Thank you, Dr. Mohammadi. I do have, oh, okay, there is a question here. So for 11-year-old who will turn 12 soon, is it recommended to give the vaccine the minute they turn 12, or can we wait, or should we wait?
That's a great question. First of all, why did we pick 12 as an age group to start with? Well, it's very arbitrary, in all honesty. There's nothing magical that happens when you wake up one day and you turn 12, although most 12-year-olds will disagree with me in that fact. They feel different that morning now that they're 12, but biologically speaking, there's nothing that happens in one day that makes it somehow better to get it at age 12 versus age 11, for that matter, age 13 versus age 12, or what the case may be. We picked these numbers because we needed a number as a cutoff from a study standpoint, from a approval standpoint, from a protocol standpoint. Okay, the simple answer is the sooner you get the vaccine when you are eligible, the better. I think it's, again, from the standpoint of, is it going to change the outlook of the likelihood of a reaction? Is it going to change the efficacy if you wait a week, a month, a year? No. But every day we wait, it's one more opportunity that you can contract the COVID. It's one more opportunity for the disease to cause harm in that individual. It's one more opportunity for that individual to transmit it to somebody else. So, yes, earlier the better when eligible.
Thank you, Dr. Mohammadi. A follow-up question to the presentation in terms of the immune response after getting both of the vaccines. I know that in the news, they've been talking about that adults who received the vaccine earlier this year or even late in December might be requiring a booster shot, either starting August-ish, and onwards. And I know the data on the vaccines for these 12 to 17 is not as comprehensive yet. Are we also somewhat looking at that for this group as well? Or because because they are young, their immune response is slightly different than us adults. Are we looking at something different from that as well?
Yeah, that's a great question. So the short answer is you're right, we don't know. Let me take a step back though, as to why we might need that booster. So there's two aspects to the booster. One aspect is, does our immunity to the COVID vaccine, does it wane after a certain amount of time? And the answer to that is likely yes. The amount of protection that we have from the COVID vaccine within the first 9 months of getting the vaccine is definitely higher than what we anticipate will be the case at, say, 15 or 18 months after the vaccine, okay? So that's one aspect of it. The second aspect is, where will we be come, August, September, October, November, December, when it comes to the variants? And so the boosters may need to address both of those aspects. So if there are variants that are predominant within the community that are less impacted, or we have less immunity to, compared to the wild type, the original vaccine or the original virus that we had the vaccine developed to, if those variants are, able to overcome these vaccines to some degree, then we may need a booster that takes into account these variants. So far, what do we know though? The nomenclature here, the naming of these has become very confusing. So I'm going to sort of use both the World Health Organization and the lay name for this is, we talk about the UK variant, also referred to as the Alpha variant. What we know about the Alpha variant, the UK variant, is that the vaccines that we've been using have been quite effective. Are they as effective as they are against the wild type, the original version of the COVID virus? No, but to this date, what we know is that the severity or the consequences of breakthrough have not been significantly different. More people have gotten some mild cases compared to the normal variant with the UK variant, the Alpha variant. So we do know that at least against the Alpha variant, the UK variant, we have good protection. Where we're a little worried is the Delta variant, the one that's associated with India, the variant that's coming out of India. And there's some concern because it is present in the United States. The efficacy of the vaccine that we have currently is not as potent against that variant. And we also know that it is substantially more infectious and to some degree more severe when you get that variant as the cause of your COVID disease. So how do we then work against that? Again, the more people we get vaccinated now, the less likely we have to worry about variants in the future. I'm going to say that one more time. The more people we get vaccinated now, the less issues we will have dealing with variants in the future. Because some protection is still better than no protection, and some protection will still dampen the ability for it to spread within our communities. So again, for the adults who might be listening who haven't yet gotten vaccinated, take that into account. And so the same applies for our children. Getting them vaccinated early will help with our ability to deal with some of this downstream. And the more we get vaccinated now, the 3 months that we have before school starts, the more likely we are to not have problems with getting kids into school, keeping them into school, having a normal aspect to their lives I would argue that they've probably been more affected by this than adults have. And so I think it's important that we take that into account as well. I hope that was a long answer to the question.
But it was very comprehensive. Again, very detailed. Detailed answers are good because it takes away that uncertainty that the parents are feeling right now. There's so many parents who are on this, border, teetering on the border, saying, should I or should I not? And many of the parents that are questioning, we have teens, and as we are growing, we have so many allergies. We outgrow them as we get older, but when we are younger, we still have those allergies, or our immune systems are still developing even at 12, 13 years of age. What would you recommend, or how are you going to console those parents that whether they should take this vaccine or not? So, and I know that you did say that you have a 13-year-old. So, how did you feel about that? And if you
no, I think that's,
that.
absolutely. That is the crux of all of this, is that, it is an individual decision. You have to weigh in all these factors into that decision. And we did not take this decision lightly when we made the decision. It was very new. And so we investigated, we looked at the data, reliable data, and we looked at, the responsibility aspect as well. There's more to this than just, my own son. I'll be very blunt here. There's more to that decision than me saying, well, what's best for my child? Because it is a community responsibility to some degree when we talk about vaccines. This isn't about individuals. This is about communities. This is about our role in society and how we sometimes have to take certain risks because we live in a society. Just like others take certain risks for our benefit, we do the same likewise. So when we make these decisions, and when I talk to other parents who've asked me, did you vaccinate your child? I said, yes, we vaccinated. We looked into it. I did the research as best as was available at the time. And frankly, we have a lot more now than when I made the decision to give the first shot. And even the second shot, I wanted to make sure before I gave the second shot that it wasn't just a reflex reaction. Oh, he's already got one, we give the second. I looked into the data. I looked, and we even hesitated to some degree because at that point, the data for the myocarditis was coming out. So when it was his turn at 3 weeks, I said, let's wait 1 week. A week's not going to make a difference. Let's look at the data and let's see where we're at in a few days, and we can always give the vaccine then. So, and I tell parents that I've talked to the same thing. At this point, the vaccine is considered to be extremely safe. We've collected all the data for that first batch of kids that have gotten the vaccine outside of the study. And they're outside of this small risk of the myocarditis. I bring it up right up front because I know that's the important aspect. Outside of this very small risk of the myocarditis, we are not seeing any different concerns from the vaccine being given to 12 to 15-year-olds.
Thank you so much. I do have another question. And this question is in regards to parents who choose not to vaccinate due to whatever reason their children. With the coming new school year, some students might not be vaccinated. Do you think that there are concerns about students performing school activities such as with other kids? For example, swimming, playing basketball, or any other close contact sports, or being in a room that might be a little bit smaller than, having that 3 feet distance?
Yeah. So again, I'll speak specifically to the 12 and up age groups, okay? Because I think right now we can't speak to the 11 and younger at this point. I don't know where and when and where we'll be in, by February, but again, that group is less of a concern overall, which is why we can put that on the back burner to some degree. But for the 12 and up age groups going back to school, yes, there's risks for going back to school when you're not vaccinated. And what it'll probably come down to at that stage is what we've done with pretty much all other vaccines. You have to have a very compelling reason not to get vaccinated when we talk about measles, when we talk about other vaccinations that are required for school-age kids that are communicable, particularly measles, pertussis being the other one, these kinds of diseases. We require that for our children to go to school. And this shouldn't be any different. Now, it is different, though. It is different because right now, as it stands, we're considering it a little bit outside the norm in that the FDA has not fully approved the vaccination. It'll come probably within the next couple of months, I hope. But in all honesty, that's the one exception to this situation compared to the others. Do we have enough data that the FDA should approve it? Absolutely. We have more data on these vaccines than we have on any other vaccines that we've ever given in the history of vaccines. So there is no reason why the FDA won't ultimately approve this. However, the delays involve certain other political aspects that I won't get into, but also one practical aspect in that because of emergency use, the government is paying for a lot of this stuff so that you don't have to.
Yeah.
Right. So we don't have to pay, when on these vaccines that many people would not have been able to afford had it not been paid by the government. That's why, to some degree, it's emergency use, and therefore, it benefits us that the FDA hasn't approved it.
Correct.
And left it as an emergency use. So I don't want that as the FDA hasn't approved it, therefore it's not an approved medicine. No, there's a practicality aspect to why the FDA has not approved it, but at the same time, that approval's going to come. We know it. There's no doubt that that'll come. It's just there's other aspects that are delaying that. So should your kids get vaccinated before next year, if they're eligible, getting vaccinated before the next school year, I think it won't be a question of should, it's going to be a question of, yes, they're going to have to because the schools are going to require it. We're already looking at colleges requiring it. Many colleges have adapted that as part of their requirement for return to on-campus learning. Now, whether or not some schools will provide some opportunities for off-campus learning still for people who can't get vaccinated for one reason or another, or whatever the case may be, that's going to be probably dependent on school districts. But for the most part, I think they don't want to have kids trying to do this at home anymore because we know it's less effective a learning tool than trying to do this in person.
Yeah, and it also is taking a toll on the social and emotional health
Absolutely.
of our teens,
Absolutely.
our young ones. I do have some follow-up questions to this that, when teenagers or the 12 to 16-year-old group is in school and we have a mixed bag of unvaccinated and vaccinated students, and we are looking at the flu season coming up as well, and that's another area that we haven't gone through yet because we were all quarantined last year. How are we? I know not much data, so you probably are going to be speaking from your experience or from your studies. How is it going to be dangerous? Is it going to be less effective for students who have been vaccinated, teens who have been vaccinated, to be around unvaccinated students or teens around? Are we looking at complications due to that for vaccinated and unvaccinated teens?
So here's the issue. If you have just to make the numbers easier to deal with, let's say you have 100 kids in a class, not a classroom, but 1 year, one class in a school. And let's say 50%, 50 of those kids are vaccinated and 50 are not. What does it mean for the 50 that are vaccinated and the 50 that are not? Well, the 50 that are vaccinated, you know, as best as we can tell, 90+% effectiveness. So thinking about it that way, about 45 of those kids are protected.
Yes.
5 of them may not be. Now, what does that mean for that 5? Well, it doesn't mean that they're going to get hospitalized, but they may get a mild case of COVID. And they may then potentially transmit it back to people who are not vaccinated, who then would say, but my child is vaccinated, or I'm with this person who's vaccinated, you know, my risk is low, therefore I don't need to be vaccinated. So those are how the numbers play out to some degree amongst that 50. Now, amongst the other 50 that are unvaccinated, again, their risk is going to be that of what we have been experiencing all along. And so they're going to remain at risk for potential disease, but also for potential severe diseases and the complications that come with those diseases. Will they get them? No, it's a probability. It's a, you know, there's to some degree a chance aspect to that. And, but I will say the longer you are in that group, the more that chance increases because you're constantly exposed, especially as we get to a point where we feel like in the community it's dropped down enough, or we vaccinated enough people that we start, you know, going back to normal behavior, opening up restaurants, masking less, you know, dropping all these protections that we've been having that have been effective. And we know they've been effective, as you mentioned, because flu has been unheard of this last year. Yes. There was, I mean, virtually no cases of flu that we saw because people were masking, because people were, you know, social distancing, because people were washing and keeping everything, you know, safe for themselves. We didn't see flu. I am a very strong proponent that every flu season we should probably be masking. And if this year hasn't been proof of that, then I don't know what will be. But getting back to the point of what do we do about the kids? Again, if we get 50%, you know, vaccinated, for that's how the numbers would play out of a class of 100 or so. Multiply that by 12 grades, or actually not 12 grades because we're talking about 12 to, you know, 18, so 6 grades at best, and then multiply that by every school that's in your community. Okay. Now, if we're talking about 90% vaccination, those 10 kids, let's say now that were 5 before, but the 10 kids that the vaccine was less effective in are at still lower risk because they're not around 50 kids that are unvaccinated. Now they're around a potential 10 kids that are unvaccinated. And therefore their risk goes down substantially as well, okay? So again, it's purely about the numbers. The more we get vaccinated, the better off everybody ends up being.
Even against the Delta variant as well, right, Dr.
Absolutely. Yeah. So even against the Alpha, the Delta, all the variants that are coming out, the more we vaccinate. So let's say now that 90% efficacy goes down to, I'll give you, you know, a conservative number of 60% efficacy. Yeah. So if we have 100 kids, 50 are vaccinated, and we have a predominance of the Delta variant in our community, 60% of those kids, which would be 30 kids, are protected, 20 are not.
Yeah.
Okay. And now we're talking about different numbers again. But when we get to 90% vaccinated, then that number approaches, 60 of the kids are vaccinated out of that 100, are protected out of that 100, and a lot smaller fraction overall are not.
Correct. Yes. Thank you. Now there, because there's lots of conspiracy theories out there. As a Muslim doctor who practices, and what are some conspiracies behind this vaccine, especially when we're talking about our children between the ages of 12 and 17, and that you have heard and you would like to rebook, basically?
Yeah. So the biggest one, I think the one that sort of gets circulated the most would be the issues of fertility. There's nothing to suggest that these vaccines have any effect on fertility at all. Adults or children, regardless of age, regardless of gender, there's nothing to suggest that these vaccines have any effect on fertility. So if that's a concern that you have, you can at least put that out of your mind. These are concerns that crop up as a small statement in one forum and then get amplified, and then you say, well, a lot of people are talking about this. And just because a lot of people are talking about it doesn't give it any more validity than if only one person had talked about it. So we have to go back to what we know and what we study and what we have experience with, based on things that we can reproduce, things that we can validate by study, by experiment, and have not one individual do it, but multiple individuals do it the same way and say, yes, we achieved the same conclusion based on this information. And there's been no evidence from that standpoint that anybody has raised that can say, oh, here's why we're worried about fertility. The worry comes from people saying, I'm worried about fertility. And now it's an issue. It's a concern that somebody has, and it gets amplified and amplified. And then we have to go around, saying that, no, that's not a worry. We had the same issue, but with, more difficulty with the measles, mumps, rubella vaccine. Somebody raised a concern, one individual falsely raised a concern regarding autism and the measles, mumps, rubella vaccine. And now it's a, spread rumor, and there are a lot of organizations, and we've had to spend millions of dollars as a medical community to keep on doing a study that shows that what we already know, that there is no link between the measles, mumps, rubella vaccine and autism. So it's the same issue here. And so when you hear about things that, well, this causes this, or there's some concern about this, it's worth asking, well, where do you get that concern? What is the data to support that that's a concern? We had no, so if there was truly some sort of conspiracy here, this myocarditis question would never have been revealed out to people. We wouldn't have been openly looking at it. We wouldn't have been openly discussing it in multiple infectious disease forums to say, okay, is this real? When it first happened, there was only, a handful of cases, and we were like, well, that's enough for us to be worried. Let's look into it. Let's find the data. Let's explore this. So where is that data for some of these other concerns, like fertility?
Or even autism.
What's that?
Even autism, that might be
same thing.
soon.
Yeah, no, I'm sure that'll come up with this vaccine as well eventually. Some of the other sort of more fringe concerns I won't get into, but you probably heard them all: the chips, magnets, 5G, I could go on and on. But again, when you think about the biological plausibility of things, you have to put that into perspective with all this stuff. And you have to be able to say, okay, is that even something that could be done? And why?
Oh no, Dr. Ahmadi, I think we have lost you. Dr. Mohammadi? Dr. Mohammadi, we kind of lost you.
Okay, can you hear me now?
Yes,
Okay, good. Sorry about that.
no worries.
Yeah, so I think I was on my soapbox about
I see, and
5G.
that's why the internet conspires.
Yes, exactly. This is proof, right?
Yeah.
So again, I just say, is there some sort of biological plausibility to a concern? And if there is, I assure you, there are researchers who are more than willing to investigate it. But when there's no biological plausibility to a concern, then no, it's not worth even, spending that energy to try to convince that person, because in all honesty, I don't know how I'm going to bring them back to the benefits of a vaccine, but also just to be cautious ourselves, not to go down those rabbit holes, not to go down those paths where we're sort of sucked into these unusual conspiracies that, somebody's uncle started on a Facebook post.
WhatsApp medical universities.
Yeah, exactly.
Liking them. I really greatly appreciate this conversation with you, Dr. Mohammadi. As a geneticist myself, I really enjoyed learning about this vaccine, especially for our teenagers and our young students, and for the parents to put them at ease. And I know, we are a little bit over our time, and I do have one last question. Again, to reemphasize the importance of this vaccine for our 12 to 17, 12 to 16-year-olds, that, and it's a yes and no question, kind of yes and no question, that, if you're fully vaccinated, and the recommended for the young ones right now is the Pfizer vaccine, which is 2 shots. If you're fully vaccinated, and would you be able to still, actually have another question coming up for you right now, would you still can get COVID and pass it on to others as well? And another question that just came up as well is, if you're a parent of a 12-year-old and they're claiming that the Pfizer is a experimental vaccine and not know the long-term side effects or efficacy, what advice would you give to those parents about that? And I believe that would be a closing remark as well on your part. Thank you.
Yeah, absolutely. So to the first question about transmissibility after being fully vaccinated, we know based on adult studies that the transmissibility drops down substantially. So the likelihood of you getting infected drops down substantially. But even if you are infected and have a mild case, your viral loads are lower. Mm-hmm. And therefore your ability to infect somebody else is lower in that setting, okay? So keep in mind, the vast benefit comes from just not being infected in terms of transmissibility. But even if you do, remember, like I said, 95% efficacious for adults, the Pfizer, the Moderna, or more, as we know, for the original, and likely close to that for some of the more common variants, that even still, our risk of transmitting it becomes much lower than had we never been vaccinated. So the benefit there is definitely there from that aspect of transmissibility. The benefit to our community is there from that aspect, from the transmissibility question, okay? And then the other part of this is the long-term effect. So I'm gonna, again, we don't know. The honest answer is we don't know. But what do we know about this technology? We've had it around since 2003, and we've used it in other settings, not as a widely used vaccine, but when we had it for the original SARS-CoV-1, right? MERS, those settings, we have experience with the vaccine long-term, and we have not seen any concerning findings. Fertility, mutations, genetic variation, all that kind of stuff. There's been no evidence of that. So to say that we have zero data is probably underestimating what we have, but we have some data to say, no, we shouldn't be worried about the effect. Now, last time I talked about how the vaccine works, how the messenger RNA component of it never gets into the nucleus of the cell where our DNA lives. And keeping in mind that messenger RNA is not stable enough to stay in our system long enough afterwards to cause any kind of issues downstream. It's there for enough time for several of our cells to make the spike protein and for our immune system to then react to it. And then it degrades. It's part of the reason we have to keep it frozen is because it's so unstable that, it doesn't linger even in our own bodies. So because there's no biological, process by which we would expect genetic mutations down the road or, other consequences down the road, we feel very confident, and by we I mean the scientific community feels very confident that this is a safe vaccine when compared to other vaccines. That being said, it is a vaccine. Its purpose is to induce immune response. So will there be a small fraction of people in which that immune response gets confused and causes potential autoimmune problems? Yes, but those people were probably at risk of that anyway. They're probably already identified and they're probably at risk of that anyway. And are there managements for that? Are there treatments for that? Yes. So is there downstream consequences to the vaccine? Absolutely. Are those consequences extremely rare and manageable? Absolutely. Is there enough of that to outweigh getting the vaccine? No. And that's true for adults, and that's true for 12 to 17-year-olds, okay? I will not speak at this point about under 12 because we don't know, I think that group, really we have to do immense amount of study in much larger groups before we're gonna feel more confident about that aspect of things. So that data may take a while, and that's okay, because I think that group is probably the least of our worries.
Yeah.
So if we can still focus on 12 to 90 to 100-year-olds, that's the group we have to focus on right now. And that's the group that we have enough data for me to confidently say that the benefits of this vaccine outweigh the risks. Yeah. Okay. By a large fraction, not mildly, but immensely outweigh the risk. And the overall benefit to our communities is going to be helped by getting even our kids 12 and up vaccinated.
Thank you so very much. Dr. Mohammadi. One last question, or actually, people are asking where can we go to get more resources and information about this vaccine for the teens? What are some websites or information places?
Yeah, so like I had mentioned, the organization that is responsible for vaccine schedule and vaccine recommendations is meeting as we speak. They started their meeting yesterday. They're meeting on these topics right now. And I have no doubt that by middle of next week or end of next week, they will publish some information that kind of very uniformly as a organization says, here is our recommendation. Here's what you need to worry about with kids. Here's what you don't need to worry about with kids. So I would say that's coming. Okay. And when that does come out, I will forward it to the MET folks to put on their website so that it'll be easy to access. Outside of that, right now, the best source is the CDC website. And the CDC has lots of information, not only about adult vaccine, but also for the kids. It also talks about the myocarditis aspect of things, and and talks about very openly some of these numbers that I've already talked to you about. And I assume my slides, I'll send it to the MET organization, yes, if they want to have those slides. But again, they're on YouTube now, so you should be able to go through them and see. And like I said, the slides that kind of where I outlined what is the benefit versus what is the myocarditis risk, I think really one should take to heart, because that is what we're talking about, preventing these problems by getting the vaccine.
Thank you so much, Dr. Mohammadi. It was, again, a pleasure to have you and an honor as well. The aim and the goal of Muslim Educational Trust is to educate our communities, and as what your goal is in life as well, that you said you want to teach, you want to educate, propagate the knowledge that you have, and that's what we aim to do at Muslim Educational Trust for past 28 years. And I thank you and thank everyone else who's watching this and join us and ask all these questions today. Have a great evening.
Thank you very much. Again, thank you for this opportunity. I'm always happy to work with the MET because I feel like our goals are the same, education for everyone. So again, thank you for this opportunity. The MET has my contact information. If there's specifics that I can help address, I'm happy to do so. But for the most part, I think, your pediatricians, if there's, specific questions for your child, your pediatrician would be able to answer that. When it comes to any vaccine, but also for the COVID vaccine. And they have these resources and they're already, fielding these questions as well. So that's another good resource for parents who have questions about the vaccine.
And I do know that several organizations, OHSU is doing a drive-through clinic on Saturday morning, and on Sunday a walk-in as well at the different Multnomah Pavilion and Hillsborough Stadium as well. So parents, if you're watching and you're inspired, please go vaccinate your child, inshallah. Take care. Good night. Assalamu alaikum.
Wa alaikum assalam.